Welcome back to the Voices of Healthcare Equity, Part 2, with Dr. MaryAnn Wilbur. In Part 1, we talked about how Dr. Wilbur's background, coming from a poor family with no previous physicians or college graduates, then going to medical school and realizing that social determinants of health and equity were not part of the curriculum, being an entrepreneur even before she was a doctor and creating an elective outside of the curriculum to talk about physician advocacy and social determinants of health, and then becoming an OBGYN and a GYN oncologist, where she became frustrated that the incentives within healthcare were not actually promoting public health or health for the individual patient. And now she is an advocate for equity and has formed a consulting company and is saddened that her great medical skill that has taken over 30 years to form is not still being engaged in medicine at the same time as advocacy. The perfect world would be all those parts of this incredible, talented individual would be engaged in medicine and towards helping patients.
Thank you.
Welcome back, MaryAnn.
Yep, all true. Kind of crazy. I haven't operated now in almost 2 years, but I dream about operating most nights. So it is still a very big part of, so GYN oncology, we're mostly surgeons because most of the cancers that are treated by GYN oncologists are largely treated surgically and then followed up by treatment, systemic treatment. So largely we identify as surgeons. And I still in my brain identify as a surgeon. I'm just a surgeon who no longer operates, which is odd, but no less committed to making things better.
Yeah. A temporary situation, because in the Healthcare Alliance for an Equitable World, we're actually working to take the specialist training of people like yourself and bringing it to the 84% of the globe, not just the United States, that do not have access to healthcare. And one of the programs we are involved in is cervical cancer for very under-resourced areas in South Africa. And our teams can consult with the medical teams on the ground to help get those early cervical cancer screenings done and treatments performed for people that need it. So we're hoping to kind of change that conversation. So in part 2 here, this is it. We're like, we know the problems. You know what? We know who needs to solve it. It's you all, clinician community, please. Yes, we need to solve it. We, the people that know it and have embedded in us advocacy and do no harm and fiduciary responsibility. Super fancy term that means in the core of everything a doctor does, they put the needs and the outcomes of the patient ahead of themselves. There are very few professions where people take an oath and build their whole career around putting other people ahead of themselves. And those are the people that you want in charge of building your healthcare system, not the people whose job it is to put themselves first. So let's step up and let's create a better system. So one of the things about medicine is it has all these crazy, wonderful ideals about how people should take care of themselves. And we're always telling patients how they should take care of themselves. But when push comes to shove, medicine doesn't take care of its own people. So when you had a need for time with your family as a resource that you cannot easily replace, y'all, to get just a family medicine physician is 30 years. To get a surgeon, throw on 5 to 7 more years. This is like a golden gem that you should be holding on to because you can't find another one for another 35 years. So instead of supporting that, what medicine does is says, suck it up, buttercup. Keep focusing on that fiduciary responsibility. Please get the best outcome for your patients, but not for yourself. And nowhere did that become clearer than in COVID, right? I bet you COVID is part of this story.
Oh, yeah. COVID is often a part of the story, but it's important that we are all aware that it was not the virus that made that made everything worse. These problems were here. They were bad. We all knew it. But COVID functioned as a catalyst. So it really sped up the process and really underscored the issues. And COVID was a part of my own personal story. And so what I've been doing now for the last 2 years is talking to our colleagues, our physician colleagues all over the U.S. about, because I mean we have global issues for sure, but really I focus this particular time around the physician shortage in the US has been a big part of what I'm doing these days. And so I've been talking to our colleagues across the US and that came out very consistently. So what we were doing is interviews. I've been talking to them and then turning it into this book. And yeah, they all said it's there was one person that I talked to. I literally cried after the interview. So if you think my training is impressive, this lady is amazing. Um, I remember it's all anonymous, and so I'm going to try to make sure that I don't say anything that is, gives away her identity. But it is a female trauma surgeon who then went on, did a critical care fellowship, then went on and got an ECMO, uh, special, like spent a whole year specifically around ECMO, which is a heart-lung bypass machine. So this person is qualified to take your gunshot wounds to the OR, manage your ICU, and can do a heart-lung bypass in one person. That is one skilled human. And this person is such a gem of a human and just kept working because the heart-lung bypass was used a lot during COVID. And so she just stepped up and she worked and she worked and she worked and she worked unsupported until she couldn't do it anymore. And now she's left medicine forever. And like, I get goosebumps every time I think or tell that story. I think about it. For me, after that interview, I went back to a feeling I had not felt since I was 8 years old, because I was 8 years old the day the Challenger exploded. And I remember thinking, oh, like that's so much humanity and brain power and everything just was lost. And that's how I felt when I interviewed this woman. I was like, oh my God, the gifts to humanity that are her personal qualities and her skill set, the gifts. And this person, she's so young. She doesn't even have gray hair yet. I mean, maybe she did. Maybe she was covered. I don't know. But she, had 30 years to go. I mean, so many lives that she could have saved and so many things that she could train the next generation to do. And she got to a point, she said, I was so depressed. I considered suicide. And the only reason I didn't do it is because I didn't want to add one more corpse, one more body to have to care for. So I walked away. I was like, that's what we do to an amazing human like that. That's what we do. We just break them. I'm going to cry again. The system is so messed up.
Thanks to that amazing individual for sharing their story with you and for you sharing it. You are 100% correct. COVID, the virus, has not caused a burnout epidemic among physicians. It just made something that was slowly and indolently infiltrating medicine painfully obvious to everyone. And what that something is that physicians, nurses, clinical teams are not the focus of the healthcare system. Patients are not the focus of the healthcare system. It has become a very complicated economic driver and a corporatization of medical care. And that is dangerous to everybody. I don't care who you are. Are you Jeff Bezos, the most one of the richest people in the world, it affects you because when you are sick, I'm an ER doctor, sir, and I am at the bedside of people's lives at the worst moments. And there's nothing more equitable than an ER because a homeless person will be next to the richest person in the world having a heart attack. Because when you're having the worst day of your life, everybody is the same. And you know who you want on the other side of the worst day of your life? A highly trained professional. And the day is coming. We are telling it to you right now. We're giving you several years of notice to make this better. The day is coming when you will show up at the worst day of your life, something you can't plan, and you will not have the care you needed. The President of the United States, John F. Kennedy, died in an emergency room when he was shot because emergency medicine didn't exist. And look, he could have died anyway, right? But emergency medicine didn't exist that time. And so you show up at an ER and you get probably a resident who happens to be rotating in the ER that day. And those days are coming again when specialists are not going to be available at the worst moment of your life. So I don't care who you are, how rich you think you are, you can't buy everything you need.
I would argue it's already here, but right now it's really impacting communities that are isolated, geographically isolated, poor, primarily Black. That phenomenon is already occurring because ERs are closing in those communities. So it's getting harder and harder to get to those locations. And even when you do get there, the resources are stretched thin. And people ask me, they're like, when is the change going to happen? And I say, I hate to say it, but I think as soon as a senator's son shows up into an ER and has a heart attack before seeing a doctor and dies, that's what I think it's going to take. I mean, we've been saying it. There was a brilliant article published in Time magazine like 2 years ago now saying this. It's not like we're not being dramatic. This is happening, but nobody's really ready to make change. I mean, we lean towards inertia, and the people who have the power to make change are currently the ones who are least impacted. And so we're in this terrible state of purgatory where we're waiting for the people with power to really feel the pain. And then the change is going to come.
I'm not completely convinced that the change we want will come unless we create the change. So let's talk a little bit about that. Let's talk about what you're doing, Dr. Wilbur, to be part of a different future, a more equitable future in medicine.
The project that I just finished is a qualitative project. So that means that I interviewed our physician colleagues all across the country about exactly what is happening, just to document what is in fact happening, and make sure everybody understands that this is real and this is why, and then putting all of those stories together into a book. And this is by design. A lot of people are like, oh, why don't you publish it in medical literature? And I'm like, one, because I don't think that there's enough space to really capture these authentic stories and to share them. And two, I don't want it drummed down to this. We did this many interviews, and it's not about data. It's about what's really happening and making sure people understand, that we all understand. So the book is called The Doctor Is No Longer In. It will be out on shelves in about 3 weeks. But if you want to support uncensored authorship and independence in publishing, please reserve your copy now. The website is www.thedoctorisnolongerin.com. You can reserve your copy, and that helps us get these books out. We actually did have a publisher, but honestly, there was some intellectual property stuff, so we actually chose to do independent publishing for this. So we put the book out, and then the very next step is a documentary, and I'm very excited about it. The target audience is everyone. I'm not allowed to say yet, but there is a major streaming network who has picked it up, and it will be available to everybody. And it's really going to be interviews with all the stakeholders, not just the doctors, but the patients, the doctors, the nurses, the insurance healthcare executives. Why do they think that things aren't changing? So everybody, because really, I believe that um, what is going to be required for change is for all of us to be informed, to understand how we got here and what we're going to have to do to make change. And step one is education, is making sure that we all have a shared understanding of how we got here. And there's no real villain. Greed is a major factor. But without vilifying anyone, we just need to understand that mistakes were made. They landed us in the situation we're in. This situation is not sustainable. And we need to make thoughtful change for all of us, for the better of all of us.
Yeah. So you're bringing voice to the why we need structural healthcare change, and you're doing it in the way that is relatable to everybody, including healthcare executives. I think academics tend to think academics and data are how you convince people of things, but it's actually stories. Everybody is keyed into stories and the emotional, how does this relate to me? And how does this, what's in it for me? So I think it's a super powerful vehicle for bringing the why to that structural change. We haven't talked about trainees, and I know that trainees were important to you when you were a trainee, and why and how this isn't part of your education. So anytime we talk about change, an important part of change is uh, in education is teaching the very young. And so in medical education, I'm sure that bringing this to medical trainees has got to be an important part. Talk to us about that.
Yes. Yes, absolutely. So I've always loved to work with students and residents and fellows, and I still do. Actually, I have one little foot in academia still, and a big part of that reason is because I love teaching. Um, I also am very involved with Medicine Forward, which is a grassroots organization that started as physicians only, but now is for everyone. So please, if you're interested in any of this, and you're a physician or a patient or anything else, medicineforward.org. It's just $5 to sign up. It's just a nominal fee to join the community. And it's us. It's this tribe of people talking about change. And there are a lot of the next generation of physicians, already joining. But it is super important because one, I love talking to learners because they see things as they could be, not as they are. They're not jaded. They haven't been trained yet to think only in terms of billing, like, all this terrible stuff that we've got ingrained in us. Um, and they see it, and it's a beautiful thing. Also, we also now have great data showing that the first burnout episode is a key factor in future physician burnout. So the earlier somebody has a first burnout episode, the more likely they are to leave medicine. So protecting our residents and fellows is going to be very, very important, and helping them understand the risk factors, the protective factors while we're making change. So for all of these reasons, you know, I love to do this directly alongside our trainees. The only reason I didn't interview them for the book was because we know training is so difficult, even today, when a lot of older surgeons especially will tell you, oh, it's so easy. It's not easy. Everybody has a terrible experience with residency, always has, always will, I think. I don't know. Different subject. But we know training is really, really difficult. And so uh, we kind of needed to take that outside of this particular conversation. So for the book, we did not interview trainees, but I love to work. It might be the next book, I think, is very specific around the system and really, really getting into the nitty gritty but then the next one after that, it already has a title, and it does involve a lot of the next generation.
Well, thank you so much, Dr. Wilbur. It's been amazing to chat with you. I definitely see the need for a future episode, maybe when the book is out. So we don't want to put too many spoilers here ahead of the book. But please go and get the book, read the book, and we'll look forward to a future episode where we can maybe get a little bit more into the book and what's next for Dr. Wilbur. Please let our audience know how they can connect with you. And you did say a little bit about the book before, but go ahead and do it again.
Yeah, please go to the website and reserve your copy. It's the doctor is no longer in.com. No spaces, spelled exactly the way you would expect. And if you wanted to email to me directly, it's mwilbur@healthequityconsulting.org.
Amazing. Please read the book, get the book. It's a really important conversation for every single one of us. And that's going to wrap up our episode today with Dr. MaryAnn Wilbur. In our podcast, we frequently highlight and explore the vital role of collaboration between public and private enterprises, backed by government support for sustainable healthcare equity innovation. Please, if you're a public health officer, a public health official, a minister of health working to enhance healthcare access and equity, we want you on your show. We want to share your story and have your voice. Please contact us at Dr. T, at haew.org to secure your spot on the podcast. And listeners, we need you. Please share today's episode with a friend. Share this conversation so everybody can understand what is happening in healthcare. Leave us a review. Please leave us a review. We need to know what you're thinking. Share your thoughts so we can gear this content towards what you're interested in. And if you're interested in being a guest, please email us. You can visit https://haew.org to learn more, join us, partner, or contribute. Let's amplify this conversation for a healthier and more equitable world today.